Okay, I think we are ready to begin. Welcome to our Advances in Dementia Research series that is presented by the Alzheimer's Society of Toronto in partnership with the Toronto Dementia Research Alliance. This series discusses recent updates in dementia research and highlights dementia research studies occurring across Toronto. Today we have Dr. Netta, who will be presenting on exploring light therapy as a treatment for mild cognitive impairment. For those of you who are not familiar with the Alzheimer's Society of Toronto, I did want to give you a little bit of an introduction. So the Alzheimer's Society of Toronto is one of 30 plus local Alzheimer's societies in Ontario who are mandated to provide information, education, programming information to people who are living with dementia, their care partners, so this may be family members and friends, healthcare professionals, as well as the general public. We are open for services and we are providing services both virtually as well as in person. And some things that we want to make sure that you do know is that a referral is not required to access our services, and we provide services for all dementias, not just Alzheimer's disease, and that we provide services for the whole continuum. So even if you do not have a formal diagnosis and you're questioning, you can certainly contact us, and we will continue to provide support for care partners, the family and members and friends, even after the person has passed away. If you wish to see what we have happening in our societies, I would encourage you to connect with our calendar of events, and the website is provided below, https://alz.to, to find out what's happening. We also do have an education platform where you can access our various webinars that we have for families as well as for professionals, and you can access our our e-learning platform on www.alzeducate.ca. I'd also like to introduce you to our partner, the TDRA, which is the Toronto Dementia Research Alliance. Established in 2012, the TDRA is a collaboration among the University of Toronto and affiliated academic hospitals, including Baycrest, the Centre for Addiction and Mental Health, Ontario Shores Centre for Mental Health Sciences, Sunnybrook Health Sciences Center, Unity Health, and the University Health Network. The TDRA is working together to better understand, prevent, and treat dementia by creating a stronger link between basic science and clinical research, embedding research into care, improving outreach and education to the community, and increasing the efficiency of collaborative research processity. So I'd like to hand it over to Natalie, who is from the TDRA, to tell you a little bit more.
Thanks, Julie. We can just move to the next slide. Great. Okay, so we've partnered with AST on an initiative to try to make research a little bit more accessible to everyone. So the Toronto Dementia Network, or TDN, is a website that lists dementia-related programs and services across Toronto. And on this website, we created a section called Research Studies, which lists dementia studies that are open for participation across the city. Each study that's listed there is led by a TDRA-affiliated scientist and has been approved by a research ethics board. And there's tons of studies. There's studies for people with Alzheimer's disease and other types of dementia, mild cognitive impairment, healthy volunteers, and caregivers. The studies are all summarized in plain language, and to get started, the website link is shown here in orange. And information about the TDN can be found on both our website and the AST website as well. Next slide. So on the TDN, there are two main pathways. You can either browse for a study using search terms, filters, and quick searches. And when you find a study you're interested in, you can fill out the contact form to be connected with the research team who will enroll you in the study if you're eligible. Or at the bottom here, if you're not sure where to start, you can fill out a questionnaire to be matched to a study. And any information you enter will be securely stored and protected. Next slide. And this is what the website looks like. So when you're on the page, if you're looking for something specific, for example, Alzheimer's disease studies, you can type that in the search bar along the top, and you can either hit submit with that term or apply more filters like the type of study or the age group, location, etc., and then hit submit. Alternatively, you can use the quick search buttons we have in the blue boxes. If you'd rather just fill out a questionnaire to be matched to a study, you can click Match Me to a Study quick search box or scroll to the bottom of the page and you'll see an orange button that says Can't find a study you're interested, and that will also take you to the questionnaire. So all the study summaries, as shown in the BEAM study example on the left, describe what the study is about, who can participate, the location, and the time requirement. Again, it's all in plain language. The study being discussed today will be listed on the TDN in the coming weeks, we hope, so you'll be able to read more about it there and get in touch with the study team from there. And next slide. Great, so now I'd like to introduce our speaker. And before I do, just a reminder to keep any questions till the end of the webinar for our question and answer period. If you do want to enter them in the chat box throughout, that's great, and we can get to them at the end. So we're grateful to be joined today by Dr. Neda Rashidi Ranjbar, who is a clinician scientist with experience in clinical and cognitive neuroscience. She completed her medical doctorate at the Tehran University of Medical Sciences, and she holds a Master's of Science degree in cognitive neuroscience from Trento University. Dr. Rashidi Ranjbar also completed a PhD at the Institute of Medical Science at the University of Toronto, where she studied alterations of brain networks in people living with Alzheimer's disease at the Center for Addiction and Mental Health. She is now based at St. Michael's Hospital, where she is working on the study that she will discuss with you today. So welcome and thank you for being here.
Thank you for having me. Let me start by sharing my screen. Do you see it now?
Yes.
Okay, great. Okay, so I'm excited to introduce an innovative technique, a form of light therapy for amnestic mild cognitive impairment in the context of a clinical trial that we are now running. My talk has two main parts. In the first part, I will walk you through brain changes in neurodegeneration, and then I will introduce photobiomodulation technique or light therapy, and then the current evidence that supports its effectiveness for MCI and Alzheimer's. And then in the second part of the talk, I will introduce our clinical trial. I will talk about the device that we are using for photobiomodulation or light therapy, and what measures we are taking to evaluate the effectiveness of photobiomodulation in amnestic MCI patients. So it is important to distinguish between normal aging, mild cognitive impairment or MCI, and a neurodegenerative disorder such as dementia. In normal aging, the body and the brain gradually slow down, but the cognition and intelligence remain stable and intact. In MCI, which is a state between normal cognition and dementia, there is usually a problem with memory or language, executive functioning. It can be one or more of those. And the problem is that it's greater than expected for their age. However, the person with MCI still can carry out everyday activities and be independent. And then person with dementia has severe cognitive decline, which interferes with their daily activities, and they would need help. In the MCI, it is important to note that not all MCI patients would progress to dementia. Some persons with MCI can return to normal cognitive abilities instead of progression to dementia. Some of them will stay stable over time, stay as MCI, and a portion of them, and approximately 10 to 20% of them each year will develop or progress to dementia. And then you heard that I talked about amnestic MCI. So MCI can be divided into two subtypes. If a person has cognitive impairment in their memory domain, so they have memory problems, we call them amnestic MCI. If they do not have problems in their memory, but other domains like executive functioning, they will be non-amnestic MCI. Now, let's compare the morphology of brain in a 75-year-old in normal aging with someone who has amnestic MCI, with someone who has Alzheimer's or dementia. When we compare the brain in a healthy older with MCI or amnestic MCI, you can see that the brain is somewhat smaller in volume compared to the healthy 75 years old. And more specifically, in this seahorse region called hippocampus here. So hippocampus has a major role in learning and memory and is the first place to be affected in amnestic mild cognitive impairment. And then in the dementia stage of Alzheimer's, neurons are injured and they die throughout the brain, and many brain regions begin to shrink. This process is called brain atrophy. It's widespread, as you can see here, and it caused significant loss of brain volume. And at this stage, treatments might not be very effective. Now, I want to go a bit deeper in the brain anatomy, not a lot, I promise. So a healthy brain has around 86 billion neurons. Neurons, also called nerve cells, they are the fundamental units of the brain and nervous system. They are responsible for receiving sensory input from the external world, processing it, and then sending commands to our muscles. Now, within each neuron and all our cells, there are these smaller units called mitochondria. There are thousands of mitochondria within each neuron, and there are these special compartments that are best known for their role as the powerhouse or engine of the cell, because they break down food molecules and they turn it into this energy called ATP that is now usable for our cells or neurons. Now, let's see what we know about Alzheimer's disease or dementia on the cellular level. On the left side, you can see a normal neuron. You can see mitochondria throughout the neuron in this part that is called axonal part of the neuron. These powerhouses, you can see that they have intact border and they look healthy. Now, on the right side, you can see a diseased neuron in Alzheimer's. We can see that there are some abnormal levels of amyloid beta proteins that they shape into this plaque, and they will disrupt cell function. You can also see mitochondria with this altered shape, and then also they are reduced in this part axonal level of the neuron. So mitochondrial dysfunction can lead to reduced energy production, or the ATP that we said it's crucial for cellular life, and then that can lead to neuronal death. So why is it important for researchers to understand what is happening inside in these disorders? Because when we have a clear understanding of the problem, then we can work on finding a solution or a treatment. So for instance, these amyloid plaques here, or the mitochondrial that are dysfunctional, they can be a treatment target for us for developing therapies. Now, so far, big drug companies have mainly focused on finding a solution for the abnormal levels of amyloid beta plaques. The aducanumab and the lecanemab that were FDA approved for early Alzheimer's, that includes also people with mild cognitive impairment. They both reduce the beta amyloid plaques in the brain. However, we do not still have any treatment that can actually restore or reverse the lost memories or cognitive function that is due to Alzheimer's disease. And in addition to that, like any other medications, there are many side effects to these medications as well. And then, as we saw earlier, mitochondria, the powerhouse of the cell, are also affected in the process of neurodegeneration. So several strategies have been proposed or used to reduce mitochondrial failure, for instance, using of antioxidants. But nevertheless, there is still no FDA-approved medication or drug. Now, what we propose in this study is a novel technique called transcranial photobiomodulation. It's a form of light therapy. Transcranial photobiomodulation is non-invasive and it delivers infrared light to the brain. It can be safely administered to awake outpatients, does not require general anesthesia or surgical implantation. And on top of that, there is no major side effect for it. The most common side effect that might happen might be mild redness or skin irritation at the site of the treatment. Now, how it works. So light penetrates skulls and reaches the brain. So in the brain cells, there are mitochondria, as we discussed, the powerhouse. Studies have shown and have found that inside mitochondria, there is an enzyme called cytochrome C oxidase. This enzyme is sensitive to light. It has receptor for light. So when light reaches mitochondria, this enzyme gets activated. And by activating, a chain of action happens in the mitochondria. And as a result, we will have increased level of energy production, or ATP, that is crucial for cells. So that will allow neurons to heal themselves or repair. Now, like any other treatment that are first tested in animals, photobiomodulation was also tested in animal models for Alzheimer's disease. Results from this study were actually very promising. They showed that mitochondrial function was enhanced, ATP production was increased, oxidative stress that is harmful for our cell was decreased, and it even decreased the beta amyloid plaques in the neurons and tau tangles. And also they found that the working memory of mice was increased or improved. So very promising results in the animal studies. Now, in the next level, photobiomodulation was tested in humans, but in a limited numbers. For instance, results of a study was tested in 5 participants with mild to severe cognitive impairment. They used photobiomodulation for 12 weeks. This axis here shows the weeks of therapy. So from 0 to 12 weeks, they used transcranial photobiomodulation. At week 12, they stopped using treatment and they were just followed for the cognition. And then this axis is actually showing the change from the baseline MMSE score. MMSE is a commonly used test for monitoring cognition in MCI and sometimes Alzheimer's. So when you look at this graph, you can see with the use of this method or device, photobiomodulation, their cognition started to improve and reached like a maximum at or maximum hit at 6 weeks, and it continued to rise until the end of therapy, that was 12 weeks. But when they stopped using the device, it gradually started to decline and go back. Now, in another study, they had 3 participants with Alzheimer's. They again tested for 12 weeks this photobiomodulation transcranially. The test that they used was ADS-COG. That is a standard test for cognitive testing in Alzheimer's. And again, over the 12 weeks, they started to improve in their cognition. And then when they stopped using the device at 12 weeks, their cognition started to go back to how it was. So results from these studies were also very promising. However, there were a number of limitations to these studies, including the small sample size. For instance, they only tested on 3 or 5 participants. And another limitation was that they did not control for a placebo effect. When we test a new treatment, it is necessary to control for the placebo effect, because we want to make sure that the result that we are detecting is the actual result of the treatment that we are giving the patients. So we do not want it to be an improvement in cognition because of some extra attention, for instance, or something else that we do not know. So for that reason, we would need another group, a control group that we call them sham, and I will talk about it later in the slides. So in our study, which is a pilot clinical trial, we want to use better methods and a bigger sample size to test the effectiveness of photobiomodulation in amnestic MCI. We are also interested to look beyond cognition scores, and we want to see if we can detect the effect of photobiomodulation on mitochondrial function. And from what we discussed earlier, we chose to test this potential novel treatment on participants with amnestic MCI because treatment at this stage has a better chance to improve brain function and cognition compared to the later stage of Alzheimer's. Now, the device that we are using for photobiomodulation is called NeuroRx Gamma. This device is considered a Class 2 device under Health Canada Rule 9.1. It's an active therapeutic device that is intended to be used to administer energy to the body. A NeuroRx Gamma device contains 5 treatment modules, or LEDs, one that is placed on the frontal part of the brain, 3 on the rear side, and 1 intranasal. The setting of this device is as such that it will target the nodes of a specific network in the brain called default mode network, which has been shown to be affected in neurodegeneration. So it's a reasonable choice. And then one might wonder, does light even reach the brain through skull? So several independent studies have actually looked into this, and they support the ability of infrared light technology to penetrate skull and irradiate the brain. Now, as we discussed earlier, when testing a new treatment, we need to control for the placebo effect. For this reason, we have 2 groups: the group that they receive an active NeuroRx Gamma device, another group that they receive the sham NeuroRx Gamma device. The sham NeuroRx Gamma device is indistinguishable from the active device for both patients or caregivers and the assessors. Both the sham and the active devices will be worn on patient's head for a total of 20 minutes per session at the comfort of their home. They will use it for 6 days a week for 6 weeks. And then we will also provide a device training session at the beginning for the caregiver and patient. Now, as I mentioned, in addition to cognitive testing and quality of life questionnaires, we were also interested to measure the effectiveness of photobiomodulation on mitochondrial function. So one method that is standard practice for mitochondrial disorder is a blood test. We measure lactate and pyruvate. We look at the ratio between lactate and pyruvate, and that gives us an indirect information about mitochondrial function. There's another limitation to this method, and that is we are targeting the brain with this device, and we are hoping to improve mitochondrial function. But the blood test that we are collecting is from peripheral, so it might not be like a direct measure of brain mitochondrial function. Now, what we have in our study is actually a non-invasive and a central measure with magnetic resonance spectroscopy. This is a powerful technique, non-invasive, for studying the metabolism in the brain. Our collaborators, they have developed 31 phosphorylated MRS that can actually detect the central level of ATP, which is the primary production of mitochondria. So the patient goes into the scanner. We also test their brain structure and function with MRI. They go under MRS. We select a brain region in the brain that we are interested to look at the ATP levels in that region. And then the result will look something like this. So there are 3 phosphoryl molecules in ATP. With measuring the under the curve area, we can actually have a number for ATP level in that region. So if we compare this for before and after treatment, we can see if it has actually been effective. So now this is our clinical trial in a nutshell. We are now recruiting participants. We are looking to recruit amnestic mild cognitive impairment patients, 20 patients we are looking for. They should be age 50 or above, and they should have an adequate caregiver that can ensure the compliance of the home-based treatment and to help them complete the assessment of the study. After they passed the screening and they were enrolled in the study, each participant will undergo a thorough cognitive testing and a quality of life questionnaire. There will be a blood test to test lactate and pyruvate, and then they will go under MRI and MRS to measure their brain structure, their function, and the ATP level for mitochondrial function. Then they will be randomized to active and sham. They will be given the device, they will go home, and they will use the device from the comfort of their home 20 minutes per day for 6 days a week for a duration of 6 weeks. Now, we will follow up with them at week 3. However they prefer, they can come into clinic, or we can have a phone call or a Zoom call with them. And then after using the device for 6 weeks, they will come into the clinic and we will repeat the test again. So we will have a thorough cognitive testing, quality of life questionnaire, a blood test, and then MRI and MRS for their brain structure and the ATP levels. And then we will compare the post-treatment, after treatment results with their baseline result to see if there is any improvement, and to make sure this improvement is actual and is the effect of photobiomodulation. We will compare that among the active group and the sham group. Now, use of this device in patients with AMCI may have one or more of the following benefits. It can improve their cognitive signs and symptoms, and it can improve in patients' reported general quality of life and function. And as I mentioned, there is really no related adverse events, maybe some redness of the skin. And the information, of course, gained from this study may be beneficial for other people with the same medical conditions in the future. Now, if you wanted to learn more about our study, if you were interested, you can visit this link, clinicaltrials.gov. You can search for NeuroRx Gamma for amnestic mild cognitive impairment. And I believe this link has been shared before with you. And if you were interested to participate in the study, if you had any more specific questions for us, you can contact us via these email addresses that I believe, again, it has been provided before. And now I'm happy to take any questions you might have.
Thank you so much. And for those who are in the space, I do want to let you know that this session is being recorded. It will be made available, I would say, a week from now, and both on the AST YouTube channel as well as the TDRA website. There was one question that came up for me that I'm hoping you can revisit. So earlier you talked about percentage in terms of those who would progress, who would be from MCI back to normal, MCI to Alzheimer's
Stable.
disease, so
Yeah.
to stable and towards Alzheimer's disease. I'm wondering if you could repeat those percentages in terms of those three areas.
Yeah, so what we know, so MCI in general is a very heterogeneous disorder, meaning like it's not very like linear trajectory. It's not really easy like to predict who will go to what tract or so on. But what we know is that about 10 to 20% of MCI patients every year, they might convert to dementia. So it's not a lot of percentage, but it can happen. And then the rest, it varies.
Thank you. Another comment from the room is that what you're doing is very fascinating. When is the trial starting and when will it be finished?
So we're recruiting now, so it's now up and running. And the duration, it really depends. So we are thinking about 6 to 8 months, but it depends when the patient come in and when they actually finish the treatment. So the duration of treatment is only 6 weeks, which is not a long time. And whenever they start, we'll say like after 8 or 10 weeks, it should be over if we can follow up and start right after the screening, the assessments, and then have them come back again.
I see another question. So for those who do end up participating, would it be possible at the end of the study to know which group you were in, whether you were in the sham group or the actual device group?
Yeah, I think after the end of study, when all the data was collected from all the participants, so we closed we had all the 20 participants in, we had all the data we needed, then we can unblind, because before that we are not able to unblind it for ourselves even. So we would not able to tell right immediately after the end of the treatment if someone is, but like after the clinical trial is overall for the 20 patients, if they were interested, they can reach out and we can let them know.
Wonderful. And then another question here is this particular trial the first of its kind, or are you aware whether something like this has been tried in other places like US or Europe?
Yeah, there are actually studies now happening in US. If you check the clinicaltrials.gov website and check for photobiomodulation, you can find trials in the US that are happening right now. I do not know of any trials in the Europe at the moment. And there has been other trials in Canada even, but not for amnestic MCI patients.
I'm not seeing any more questions right now, but we can wait and see if there are additional questions that do come up. So we can wait a little bit.
So they have asked, will the result be posted by you and the follow-up webinar? Yeah, definitely, we can do that, but we would need the trial to finish. It will take some time, yeah, but definitely it will also be posted on the clinicaltrial.gov, the results.
And another one just came up. So at the end of the study, if the results are promising, would participants in the sham group be offered an opportunity to also receive the same treatment?
That is definitely something that we can work with, yes. I mean, I cannot really promise, but it's something that we can work with.
And are people with pacemakers eligible to participate? I know you mentioned you're looking for amnestic MCI, but are there other criteria or exclusions that you could share?
Yeah, again, like our inclusion and exclusion criteria are on this website, the clinicaltrials.gov. But someone with pacemaker, unfortunately, might not be eligible because we want them to go inside the scanner and MRI, and someone with pacemaker might not be able to go inside an MRI. It might not be safe for them.
Any other exclusions that you can think of for this particular study?
I can share let me just stop sharing. I can, there's a list, an extensive list. So they shouldn't be sensitive to light.